Good morning, everybody, and welcome to this, which is our third webinar this year. Hopefully, some of you managed to get a sight of the sunrise this morning. It certainly was amazing from here on Te Atatu Peninsula. This morning, I'm delighted to welcome Laura Deacon, who's some of you probably know. She's one of our palliative care doctors here at Hospice West, and she's going to talk to us this morning about feeding and fluids at the end of life. We will have opportunity for questions, and we'll run that as a panel as usual at the end of the session. So over to you, Laura. Thank you very much.
Thank you. So I'll just start by sharing my screen. Good morning, everyone. Hopefully you can see my PowerPoint slides there. Lovely. So yes, thank you so much for giving me the opportunity to present this webinar. As you know, this is one of the series of webinars that we've started to do this year, and this felt like an important topic. Working clinically, it seems to be something that often comes up as an issue for colleagues working in different settings. So looking at what we're going to cover this morning, really it's looking at why is this a challenging area? What do we know from the evidence, and how might we help patients and families come to an understanding around these complex issues with our conversations and communications with them. I'm hoping we can think about why feeding and fluids are an important topic, look at what evidence there is, which unfortunately is quite limited, think about those conversations, and then there's an opportunity at the end for us to have a bit more of a discussion with another of my colleagues. So please, if you've got questions throughout, please do share them through the Q&A function on Zoom. It'd be great to get your input. So why food and fluids? So I suppose the pictures on the screen give you an idea of my thoughts around food and fluid. It's such a big part of all of our lives, isn't it? We celebrate with food and we mark big occasions. When something goes wrong, we often bring food or drink to help with that scenario. As you can tell, I'm British, and so cup of tea is a huge cultural significance where I'm from. But it's also the way that we show each other that we love one another, and we nurture our children and we nurture the people that we love with food. So it's a huge part of life, and it's more than simply the fuel of life. It has such a big emotional significance, and I think that is why food and fluids can become a challenging topic as people become less well and are less able to manage food and fluids, both for them, but more often I think for their loved ones. Food and fluid becomes a topic that is very important. And we've already said that really eating and drinking is one of the most basic things that we all think about doing every single day of our lives. But when you actually break down what's necessary to be able to successfully eat and drink, it's a hugely complex topic. So as you can see, I've taken this graphic from a Royal College of Physicians document from this year, which I would highly recommend to anyone that's interested in this topic. It's a really very helpful document. But this just looks at the clinical requirements for somebody to be able to eat and drink, but it also looks at those other things that are necessary, like the environment, the right sort of food, the dentition to be able to eat and drink. And I think what this summarizes to me is it's no wonder that as people's bodies begin to fail as they approach end of life, that we lose the ability to manage all of this because it is so hugely complex. I think it also highlights to me the fact that actually managing these problems is probably not something that we should be doing in isolation as doctors or nurses. It's something we need to be working with the multidisciplinary team to manage, because I would never claim that I'm an expert around false teeth or dentition, but there are certainly colleagues who I could probably call on that would be able to help me with that if that was somebody's main issue. I think this is just really helpful to kind of summarize why it can be a challenge as people become less well. So that got away from me there. This slide is just thinking about when do we talk about feeding and fluids. So I think really the reason I wanted to show this slide is I think we talk about feeding and fluids a lot through people's disease course. Obviously, we get involved with people at different stages of their illness, and we hope that, as this graphic shows, we have a bit of time with people before they rapidly deteriorate to have important conversations. I think we all know that the reality of that is that the palliative care team sometimes does come in quite late, but throughout that trajectory, we have conversations around feeding and fluids. And often at the beginning of somebody's journey, that's about their weight loss or their hopes for being fed through treatment or being able to cope by having nutritional support. Sometimes it's around symptoms like nausea or constipation, which make eating and drinking difficult. And then sometimes as they become less well, it's around trouble with swallowing or loss of interest in food. So it really is a conversation we have throughout somebody's illness. It's just that the focus changes, I think, as their disease changes. And unfortunately, really, this list of things is beyond the scope of this morning's webinar. But clearly, all of these topics are hugely important when we're thinking about somebody's ability to eat and drink. And there's more that I haven't even included on the slide. So obviously, nausea and constipation are two of the big things that we spend a lot of time managing for patients. And they have a big impact on their ability to eat and drink, clearly throughout their disease course. So then why are we thinking specifically about end of life in this webinar? And I think the reason that I wanted to focus on end of life is I think that that's often a time at which these conversations really come to a head around feeding and fluids, because families and patients, their lives are often reduced down to perhaps one room and spending much more time together than they have done prior to that. And so the recognition that somebody's eating and drinking less, or not eating and drinking at all, or struggling to do those things, often really becomes very prominent to patients and their families. When I'm teaching more junior colleagues, this is often a slide I use when we're talking about how we might recognise that somebody's approaching the end of their life. And they're things that I'm sure you will all recognise. So those changes of deterioration, and that deterioration accelerating, fatigue worsening. And I think a big hallmark is decreasing appetite and desire to eat and drink. And I think certainly working on inpatient units, we know that when people's ability to swallow becomes compromised, and then needing injectable medications, that is often a sign that things are going to progress more rapidly from that point onwards. And so really, I often ask the question about eating and drinking because it can be helpful for me, I think, prognostically. Where is this patient, and are things changing rapidly for them? But I think the other reason that end of life is so important is that it is a thing that families struggle with. So this actually came up only a few weeks ago whilst I was preparing the webinar. An elderly gentleman who was really within the last hours of his life, but his daughter really struggled with the fact that he wasn't eating. He was a man for whom food had been a big part of his life, and for them as a family had been a big part of their shared life. And the thought that he was not going to partake in that part of their lives any longer, she found very difficult. And I think this raises why there are so many challenges around these conversations, because it brings up ethics and it brings up legal considerations around our duty to do the best for our patients and not to do them harm, but also to respect their independence and autonomy in making decisions. And I think also our role in supporting families, because in this scenario, the patient himself wasn't concerned about eating and drinking. He was much too unwell to be voicing any of those concerns, but the family were really struggling with that change in him. And I just thought it illustrated so well why this is such a big and emotive topic for patients and families. I think the other reason that it can be a challenging topic is that we know certainly historically there's been lots of challenges to medicine and to palliative care especially, around the concept that people are not being adequately fed, and that's contributing towards them deteriorating. I'm sure people may be familiar with the Liverpool Care Pathway. That was a national palliative care programme within the UK, was very well respected, but had a very unpleasant end really, where there were a series of cases where it had been felt to be used inappropriately. And a lot of those focused on the lack of provision of feeding and fluids to patients at the end of their lives. And so certainly working within the UK health system, I work with a lot of colleagues who've been very affected by that experience. I appreciate that's not been shared in New Zealand, but it highlights how challenging these topics can be. With that in mind, I thought what we would start this section of the session by doing was going through a clinical scenario. Now, this is intentionally quite vague, but I hope it feels relevant and recognisable to your practice. So I don't know where you work, so I've just talked about you. You're caring for a 42-year-old at the end of their life for metastatic cancer. They've clearly deteriorated, they're now bedbound, and you think they're probably in the last hours to days of their life. They want to die at home, and that's where you're with them, and you feel that they are getting very close to the end of their life. And the family ask you to provide them with subcutaneous fluids because they're no longer eating and drinking. So at this point, David is going to help me by bringing a poll up on your screen. If you can, I'd like you to vote for which of the three options you think would be most appropriate to offer to this patient and their family around their feeding and fluids. And we'll just give you a bit of time to come to an answer, and then we'll discuss the various options that we've given you there to talk about. We're just going to give a little bit of time to let participants have their vote. And this is really an attempt to make the webinar as interactive as possible, because I appreciate this is a conversation often best had in person, but hopefully this gives you the opportunity to interact a little with us. Okay, so David's going to bring up the results now for us. So hopefully you can see on your screen that we had 3 options there. So declining the request, negotiating, discussing and considering a trial of fluids, or offering and setting up the fluids. And it looks like really everyone, 100% of people, have decided to opt for the discussion, negotiation and consideration of trial, which is really interesting. Thank you, David. We'll close that down now. So moving on to look at those options, I thought we would talk about them all in a bit more detail. So I had anticipated most people might go for option B, and so I thought I would talk about that one first. And that's possibly because it was not a very nuanced question that I posed you, and that felt probably most like real life to you. I think this is probably the option which most of us working clinically would recognise as being our first choice. So the discussion part of this is probably the most important part, I think, because what we need to understand is what the patient or their family, depending on who's asking for the trial of fluids, what their understanding and expectation around those fluids are. Because I think the most important thing is that we're all going into this clear about what we're expecting these fluids to achieve for that patient, but also clear about some of the potential drawbacks that we might see in using fluids. And we'll come on to talk about that in a bit more detail later in the talk. But also thinking about, when we're thinking of a trial, what do we mean by that? How long might we trial these fluids for? And what would tell us that that had been a successful or unsuccessful trial? And how do we respond depending on the outcome? Option A was that actually we said no, that we didn't think that fluids were the right approach. And as always, when we're declining a patient's request or we're trying to redirect their options, it's having that conversation in a very delicate way, isn't it? So that we maintain our relationship with them and say no, hopefully in a positive way. I think the times I can think of when I've been quite adamant that trialing fluids is not in the patient's interests are those scenarios where the patient is perhaps already fluid overloaded or already has significant respiratory secretions, and I'm concerned that the addition of fluids would actually make that situation worse. And I suppose in that scenario, it's saying, I don't think that that would be the best thing for the patient, but that actually there are other things we can offer to try and manage any worries families have around thirst or dry mouth. This is the only picture I could find on the internet of a mouth care tray. I'm not quite sure what fluid that nurse has got in the mouth care tray, but we know that providing mouth care regularly, probably every 2 hours to patients, can certainly manage that sense of dry mouth and thirst for patients very adequately. And it's sometimes a nice option because we can learn a bit more about patients. You know, I often say, what was their favourite drink? What do you think they would like to have a taste of? What would you like to use on their mouth care sponges? And we've got all sorts of options that we can try. We've recently had a gentleman who had sherry on his mouth care sponges because that was the thing that he liked most, and the staff where he lived recognised that. And so even without our involvement, he was already having mouth care with sherry, which I'm sure he and his family really appreciated. Very individualised care. Option C, again, perhaps was a little bit simplistic, but thinking about offering and setting up the subcut fluids. There might be times when patients and families are very clear that this is what they want, and then we need to think about the logistical practicalities of how we might do that. And I think that brings up that managing fluids somewhere outside of the home is much easier than trying to do that within the home environment. It's practically challenging in terms of staffing and equipment and people feeling confident and competent to manage those fluids. This little graphic is something I've picked up from the NHS about where we might give subcut fluids. We tend to give subcutaneous fluids rather than IV because it negates the need for an IV line. And we think we're less likely to cause issues of fluid overload because we give the fluid much more slowly. But we do potentially risk giving people local problems like edema. And so that's why there are recommended sites for subcut infusion and recommended areas to avoid also, which this little graph shows you. So I hope that was helpful. The idea behind that really was just to get a sense of where you're at clinically, and thinking about how we can move this conversation forward, really. So when we talk to patients and families about these issues, as we do with all of the communications we have with families and carers, it's about having an open conversation and discussion, inviting them to bring to the table what their worries and concerns are. And we know that we're not very good at that around feeding and fluids. There's some data from the UK that suggests that only about a third of families have communications with healthcare professionals about feeding and fluid at end of life. And so we need to make sure that if families are not raising it themselves, that we're proactively bringing it up, because I think it's often a thing that people latterly come to worry about, or actually have as something they don't feel comfortable to share. So as a healthcare professional, if we're able to bring that to the table for them, that might be able to answer some questions for them. And really, I think when we're looking at feeding and fluid at end of life, there are probably 3 major topics that we're wanting to cover. The first one is eating and drinking at risk. So this is really acknowledging that patients, perhaps because of how unwell they've become now, are not able to do all of those complex procedures that achieve a safe swallow, but that actually for them, they get some enjoyment and some comfort from eating, and that actually they, if they are capable of it, and if not them, then their families are aware that there is a risk that if they're eating and drinking, that the food may be going down the wrong way, so causing aspirations, or potentially even choking episodes, but that for that patient and family, there's something particularly important about trying to eat. And in that scenario, it's about the patient having what they want and when they want it, and trying to make that as safe as possible. And really that's thinking about when we're giving people food. We know that as people fatigue, often their swallow becomes less safe. We know that if they are laying in bed and not in an upright position, then that is unlikely to help their swallow and is likely to cause reflux of any food contents. There are certain advice available around positioning for people with feeding at risk issues, around head tucks and actually getting them into the optimum position. We can certainly call on our colleagues in dietetics and speech and language therapy to think about how we optimize the food itself. So thinking about the texture of the food, perhaps thickened food, perhaps pureed food, and how much we offer to the patient at a time. Because if we're offering large boluses of food, obviously the risk of them running into issues is going to be greater. And I think a lot of eating and drinking at risk is around the carer's confidence, be that professional carers or family carers, that they feel confident about why they're offering this patient food and how they're doing that. Because it does feel like a big responsibility feeding somebody that is so unwell. A lot of patients might move through a phase of eating and drinking at risk and then lose the ability altogether to manage that. And so the next thing that we might then be moving to is thinking about providing them with mouth care. So we've already talked a little bit about mouth care. Really, that is maintaining a moist and comfortable mouth for a patient who's no longer able to do that for themselves. Most commonly, we do that with the mouth care sponges you can see on the screen. Patients sometimes like to use things like ice chips because they can find that very refreshing. For a small volume of fluid, that freshens the mouth a lot more. And as we've already talked about, we can use anything that patients like on those mouth care sponges. Really, it's around keeping the oral mucosa moist and clean. And also, interestingly, what we know is that the use of mouth care reduces the risk of aspiration, probably because we're clearing thick secretions that which might otherwise go down and cause aspiration issues. This is also a thing that we can do to help patients and their families feel a bit more empowered, because often, especially if somebody's in a healthcare setting, when people are at the end of their life, a lot of that care has been taken away from their loved ones, but mouth care gives them back something very positive that they can do and provide for their loved one. So it's really a very important thing, and unfortunately it is often overlooked. So moving on then to think about fluids, and this is where I'm thinking around subcut and intravenous fluids for people at the end of their life. Unfortunately, we know that really this is an area where we've got quite limited evidence around what the right thing to do is. There was a very big systematic review carried out last year, looking at thousands and thousands of papers. And really, despite all of the work that went into it, there was not very many firm conclusions that they could draw to guide our practice. And in fact, that's recognised a lot of the international guidance that we have around fluid at end of life. really very much relies upon clinician judgment, interaction with patient and family, and making an individualised plan for each individual patient. But some of the things that this study found might be helpful around having those conversations. We talk a lot about respiratory secretions at end of life, and one of the concerns has been that the addition of extra fluid might worsen those secretions. But this study found that actually that was rarely the case. So 8 studies looked at the respiratory secretions, and 6 of them found that external fluid had no impact on the volume of respiratory secretions that patients experienced. Certainly within the UK, there's a lot of discussion around whether delirium can be improved with the use of fluids. And again, that was studied quite exhaustively. There was one study that suggested that using fluids might delay the onset of an end-of-life delirium, but that was the only one that had any clear signals really around delirium and fluids. Local edema. So certainly when we're giving subcutaneous fluids, we worry about fluid pooling under the skin. There was some evidence that that could happen with subcut fluids, and there was some evidence that edema in other spaces might be made worse. So ascites especially could be made worse by the use of external fluids, but there didn't seem to be the same impact on pleural effusions. Families, sorry, my slides have got a life of their own. Families' perspectives were sought, and again, that was quite a mixed picture. So a lot of families recognised that patients naturally felt less hungry and less thirsty towards the end of their life, but still a lot of families felt that they wanted to provide food and fluids for their families because it's in some way still felt like the right thing to do for them, although they recognised that that was at odds with the disease state that their family was in. There is some suggestion from a small qualitative study that it was helpful in bereavement for those families that received fluids, but again, that was a very small study and there's nothing there that we can draw conclusive evidence on. And then probably the biggest thing that I think families ask us about is whether the use of fluids will prolong their loved one's life. So we know that when people stop eating, they can go on and live for many, many weeks. We know at the point at which people stop drinking, that actually lifespan is usually only measured in short numbers of days. But actually the addition of external fluids had very little impact on survival in any of these studies. So at the moment, we are able to say that there is no evidence that the use of fluid extends life when people are right at the end of their life. So you can see it's quite a mixed picture, really. We don't have definitive, conclusive things that we can offer people, but I think having some understanding of the worries about fluids allows this informed conversation with the families and patients. And we can safely say that if patients and family want to trial them and we have the practical means of doing that, we can do so, but we have to put certain caveats in place that if things are worse with the use of those fluids, we would have to review and think about stopping them. I've intentionally not gone into too much more detail about these challenging circumstances, but I think what we increasingly recognise is that we have more and more patients who are having complex means of nutritional support. So enteral feeding, so that's via a PEG or a RIG or via NG feeding. That's especially common, I think, with some of our patients with neurological conditions. So we know that there's good evidence for feeding via those routes in motor neurone disease. And often those families have become very expert at managing that feeding over months or years for their loved one. And so sometimes I think the discussions around withdrawing enteral feeding are even more challenging than the natural cessation of eating and drinking by somebody who has been able to throughout their disease course. And there's another even smaller subgroup of patients who then receive parenteral nutrition. So these are often oncology patients or patients who've ended up with a short bowel syndrome for some reason as a result of their underlying illness. Parenteral feeding in itself is a hugely complex topic and is usually very much supervised and managed by a multidisciplinary team. And so at the point at which somebody who's on parenteral feeding is nearing the end of their life, I would very much want to involve their already expert teams who are involved in their care to have those discussions around how to approach withdrawal of that feeding. I think for me, if you're encountering patients in the community with these sorts of challenging feeding options, then that would be a good reason to think about involving the palliative care team. We have probably a little bit more experience of managing patients using these sorts of feeds at the end of their life and different ways of approaching thinking about stopping those feeding mechanisms and how to broach that with patients and families. The other very complex area that I haven't got time to go into is thinking about patients who voluntarily stop eating and drinking as a means of shortening their own life. And that's something that is rare, but we do sometimes see in practice that patients take that option. Whether that will change in November with the End of Life Choice Act coming through, I'm not sure. But again, I think if you were meeting with patients that were expressing a wish to voluntarily stop eating and drinking, I would really encourage you to involve the specialist palliative care colleagues in that scenario, because that's challenging and emotionally difficult for staff as well as the patient. And please, if you've got questions about these things, do add them to the question and answer, and we can talk about them more at the end of the session. So thinking about how we might broach these conversations with families, I suppose really a lot of this is what we've talked about, addressing directly the issues of feeding and fluids, asking the patients and their families what their understanding is, what their worries are, and trying to give as clear an explanation as possible. And I think that clear explanation is difficult when there is not clear evidence to guide us, but it's being able to explain in a nuanced way that the evidence is lacking. But from our experience and from what the evidence tells us, this is the scenario. And I think a lot of patients and families, especially if they've known us for a period of time, will feel confident in our decision making around that. And then the other thing I've just added at the bottom there is think about the wording when we talk around feeding and fluids. I shared the example of a relative who'd used the word starve, and obviously that's a very emotive word around feeding and fluids. I think it's really helpful to help patients and families understand that if somebody has stopped eating and drinking, they're not starving to death or dying because they're not eating and drinking. They have stopped eating and drinking because they are dying, and it's that way around. We sometimes talk about, rather than not offering, we just talk about foregoing the use of these treatments, in the same way that there are other medical treatments that are no longer appropriate because that patient's at the end of their life. So we could think of the use of subcutaneous and IV fluids as a medical treatment that no longer is indicated for that person. I think really, as we've said earlier, the most important part in all of these discussions is maintaining a therapeutic relationship with patients and families, because what we want to be able to do is to maintain that relationship and support the patient and family through that experience, and also that family and bereavement. So I certainly, not long after arriving in New Zealand, had a situation that challenged me. It was my first weekend on call, and a young patient who I'd not met, one of our really experienced clinical nurse specialists had asked me to visit because she'd had conversations with the family around fluids, and they'd felt very strongly that they wanted this lady to have fluids. So the CNS and I spent a couple of hours in the home talking with the family and talking via Zoom with family overseas about what their wishes were, and where this desire for fluids had come from for this lady. And a lot of that was around the cultural significance of having tried everything and not giving up hope for this lady. She was very clearly in the last few hours of life when I met her, but we'd agreed that we would trial the fluids because it felt so important to them. And when we talk about a trial, we talk probably about a 12 or 24-hour period of trying subcutaneous fluids. We run subcutaneous fluids against gravity, so they run very slowly. And we usually use either 500 mils or a litre of normal saline. So we agreed that we would try this for this lady. The CNS returned and set those fluids up, and she died about 6 or 8 hours later with the fluid running, but with no adverse consequences from it. And so that was one of my most recent, more challenging conversations around feeding and fluids. I think in retrospect, I've no doubt that trying those fluids was the right thing for that patient and her family, because they knew that she died with them having tried everything that felt right for them. But I would say that that was probably an exceptional situation that doesn't feel like the normal situation or normal conversations we have around feeding and fluids. I think the most important thing when we agree to a trial of fluids is that regular review and rediscussion of the situation as things change. So our intention with the lady I'd spoken about was that the following day that I would return and review her, and that if we felt she had developed any adverse symptoms from the use of the fluids, that we wouldn't be trialling them again, and her family were in agreement with that. I suppose the challenging thing can be for those of us working in the community that often we're not on hand if patients do develop distressing symptoms. So it's making sure that if we're leaving patients with fluids running in the home, that there is somebody there who feels confident to stop the fluids if that's becoming an issue. And it's certainly, if they're known to the hospice, they have the massive advantage of the access to the 24-hour helpline, the 0800 number that we have through Hospice West Auckland. And certainly our nurses over the phone can often offer family support around those sorts of things. But all of that has to be part, I think, of the initial discussion, rather than setting these fluids up and then realising latterly that there's been a big issue that we've not foreseen really for these patients. There are some really good resources out there. So this is a Hospice New Zealand and Carers New Zealand poster or pamphlet that I've found through the course of preparing this webinar. This is really helpful, I think, in helping families to understand how normal it is for somebody to lose that desire to eat and drink, but also some of the helpful things that families can do. And this talks about mouth care, it talks about mouth washes, it talks about the use of soft toothbrushes. So it covers quite a lot of different options that families can offer to their loved ones. And again, it's very positive, proactive things that families can be engaged with. There's a few other resources that I would point you towards. So I've already talked about the Royal College of Physicians supporting people who have eating and drinking difficulties. It's a large and very exhaustive document. I think it runs to tens of pages, but it has some very helpful information there around the technicalities of eating and drinking, some of the ethical, legal and moral considerations that come into those decision makings. And it's a really very good resource that I would point you towards. Similarly, there's a recent Marie Curie and University College London information leaflet about eating and drinking specifically around dementia. And I think that's a particularly challenging subgroup of patients for whom eating and drinking is often an issue earlier in their disease course. So again, I would point you in the direction of that resource. Hospice New Zealand has a series of morning lectures, and there's a few recently that I think may be of interest if this is something you wanted to look at in more detail. Professor MacLeod has done an oral care lecture looking at the use of mouth care. And then there was a recent lecture by Dr. Clark looking at the use of feeding and fluid at end of life and clinicians and professionals' experience of that. And then the last reference I've got there is that systematic review looking at the use of clinically assisted nutrition, well, clinically assisted hydration for patients at end of life. And that seems to be the most extensive resource really that we have in this field. Cochrane Library reviews are also very helpful. That is a UK pilot, but it's really the gold standard for evidence. And there are quite a few things relating to feeding and fluids that you'll be able to find through the Cochrane Library. So I would point you in that direction. So I think I'm a bit ahead of time, but I think we were hoping now to move to a questions and discussions section. And I think I'm going to be joined by one of my other colleagues from Hospice West Auckland. So I'm just going to stop sharing my screen. And I'm just going to introduce my colleague, Dr. Oleg Kiriev, who's a palliative medicine specialist who works both at Hospice West Auckland and also at Middlemore Hospital, as well as the University of Auckland. Hi, Oleg.
Hi, Laura. Great. That was a
Hi.
fantastic presentation. I really enjoyed that.
Thank you. I think you've been monitoring the questions. I don't know if there's any questions that have come through whilst I've been talking.
There are a couple of questions, I think.
Sure.
I can't quite find them yet.
Oh, okay.
Here we go.
Yeah.
So one question has come in. And it asks, I feel that subcut fluids are futile at end of life and am uncomfortable when family are adamant about it. What do I do? Yeah, do you have any thoughts on that? Gosh, that's a difficult one.
Difficult, isn't it? Yeah, absolutely. And I think that feels quite recognisable. I think as healthcare professionals, we often have impressions that are formed by our own experience. So if we've had adverse experience of fluids at end of life, then that often does inform the way we feel. I think that's really tough if the family have a very clearly held positive view of fluids. And I think that's one of those scenarios where the only thing we can do really is discuss and discuss again. And sometimes, a bit like the family I spoke about, the only option we end up with is having a trial of fluids as a way of maintaining that therapeutic relationship. And I think it is setting those boundaries out before you start the trial about what the trial is going to involve and how we manage that, and at what point we would stop that trial if we feel that it's been adverse for that patient. but that is really tough. And I think
It is, yeah.
sometimes it's going away and coming back again, isn't it, to those scenarios, giving everyone a time to think and reflect.
Yeah, and I think also, especially with culturally and linguistically diverse populations, it's first, I guess, so important to reach out and develop an understanding of what their beliefs and values are, and try and create a shared understanding of what to do. So, yeah, that you know, in my experience, you know, that often does come up. Because, you know, if you don't believe in the therapeutic efficacy of a treatment, and, you know, subcut fluids is a medical intervention, a medical therapy, then it's really hard for a clinician to actually subscribe to it and undertake that intervention. So creating that shared understanding is so important. I agree.
I think often my experience is if family have lived elsewhere or people are from overseas, the end of life phase is managed differently in different countries, isn't it? And so sometimes there becomes an expectation for fluids because that is how things might be managed overseas. And so I think exactly as you say, it's understanding where that motivation comes from, isn't it, for families?
Absolutely, yeah. So looking through,
I think one of the ones that's come up that I can see, Olega, is about if people are wanting further communication skills training or courses, where they might be able to access that. And I know that's something that you've got particular insight into.
Oh gosh, yeah, that's a really tough one. Communication skills and courses. I'm not aware of any that are currently being offered specifically in this area, either regionally or nationally. There are some communication courses undertaken through the university, and also I know undergraduate education for medical students. It's a relatively common approach, but at the postgraduate level, yeah, it's a really tough one, isn't it? I'm not aware of anything. But I do expect a lot of organisations probably are running their own communication skills training within the organisation. Well, I hope so. But yeah, it's a tough one.
There are some external courses, I think, aren't there? Things like Vital Talk and the Serious Illness Conversation that would be available nationally as well.
That's right.
If people felt that this was something that they really wanted to pursue, obviously they're external courses, so there's a cost involved with them, but they might give you additional things for your toolkit, because I think all of this is about learning the principles and then being able to apply it to the individual in front of you, isn't it?
Absolutely. Yeah. It looks like there's another question that's just come up as well. So somebody has asked, I don't understand how some people are still producing urine at end of life despite not having any fluids for many days. That's a really interesting one. Have you got any thoughts around that, Laura?
Yeah, that's a great question. And I think probably those of us who've worked in palliative care a while probably also recognise those patients who seem to go on a really long time when they stop having fluids. Certainly when I've worked on inpatient hospice units, I've had a few patients who I've started to think, my goodness, I'm sure they're dying, but yet they've had no fluids and they're still with us. So looking at the evidence, people can live between 3 to 10 days is the average once they stop drinking and having any kind of hydration. Why people still produce urine is a great question. I'm not sure I have a brilliant answer to that. I suppose some people, depending on their disease, have fluid in the third space. So if they have ascites or if they have pleural effusions, they have fluid that's where it's not meant to be. I guess as they die, they may start to diurese and lose fluid from those spaces. I'm not sure for patients without those kind of conditions why they would necessarily still produce urine. Other than that, I suppose that suggests that they still have some residual renal function, and there are still some level of fluid somewhere in the body that they're finding to process.
Yeah, and look, I agree. I don't really have a good explanation for that neither. But I think, you know, from my experience, what I've noticed really is that for people who are at the end of life who don't actually have end-stage cachexia, that is, if they still have a relatively well-preserved fat reserve, then in actual fact, ongoing metabolism of their fat reserves can in itself produce water as a byproduct. And that's essentially what camels do with their camel hump. And so my understanding is that up to 250 to 500 mils of water can actually be produced through the metabolic process, normally physiologically. As to whether that occurs at end stage, with a person in the last days of life, I can't help but wonder whether that is also a process as well. So yeah, that would be my only additional thought on that matter.
That's a great question. Certainly when I was looking at resources in preparing this, one of the things that is listed as a positive of stopping fluids is that it does reduce urine output, and so the management of that's necessary either in use of continence products or catheters. And so I guess, it's interesting, isn't it? I suppose perhaps we can say that when we're talking about the pros and cons of fluids, one of the advantages may be reduced urine output, and so less need to manage that.
Yeah, that would be more typical, wouldn't it?
Yeah, I think so.
Are there any more questions? So another one's come up. If I want to organise subcut fluids for someone, who do I go to for help? Gosh,
great question. Yeah, so we know that managing fluids anywhere but home is much easier, isn't it? If somebody's in hospital or indeed on a hospice inpatient unit, we've got much more of that infrastructure around us to manage those things. And that's what the evidence shows us. You're far more likely to have fluids up at end of life in the hospice or hospital than you are at home. I guess a lot of the colleagues that are on the webinar will be working in the community. And we've had a few recent cases where we've used subcut fluids in the community. That's been working alongside the district nursing service, but actually I think in those scenarios it's been our nurses that have gone in and set up the fluids. One of the families I know was capable of taking the fluid down themselves, so there's probably a question there around how are we going to manage starting and stopping the fluids. I think if you're in a scenario in the community where you've had these conversations and you're at the point of deciding on a trial of fluids, again, that we'd be very happy from the hospice, I think, to hear from you and have a discussion at that point. It may be that the district nursing service can support you, and if they're not able to, it may be that the hospice is able to offer something additional there around supporting that family. But I think accessing the fluids is a challenge, accessing the lines can be a challenge, and then actually the practical setting up and taking down of the fluids can be a challenge. So it's not a straightforward thing to do in the community at all, I would agree.
No. I'm aware occasionally that some GP surgeries can offer subcut fluids in their surgery. Is that correct?
I think there are. I'm aware of GP surgeries that do offer sort of intravenous and subcutaneous interventions for some patients. I guess the drawback may be that by the time this patient's right at the end of their life, they may not be well enough to go into the surgery. But certainly worthwhile exploring it, isn't it? Yeah, absolutely.
Right. Good. Any more questions?
Nothing else that I can see at my end, Oleg.
All right. So fantastic. Oh no, here's one. How do you manage things when the patient hasn't got capacity to make decisions regarding eating and drinking? Do you have any thoughts on that, Laura?
Yes, so I think that's even more challenging. So the concept of eating and drinking at risk really relies on that patient being capacitous and understanding of the risk that they're taking on by eating and drinking. I think when they lose the ability to have that capacity, that's even more difficult. And I suppose we then move into a space of best interest decision making really there. Depends very much, I think, whether that person's had an EPOA nominated for health and welfare, because obviously then that person becomes a key stakeholder in these conversations. But we know that lots of our patients reach that point without those kind of things in place. And so then again, it's about collaboratively working with the family, offering our professional opinion, I think, about what is in their best interests, and helping family helping us to understand about that person and what they probably would have wanted had they been capacitous. Because even if they've not arranged things like EPOA, the family may feel very clear that they know what their wishes would have been.
Absolutely. And I think it's an area that always brings up a great deal of anxiety for health professionals. But it's important to remember some absolute fundamentals, which is firstly, that all patients are assumed to have capacity until proven otherwise, and that is essentially done through a process of formal capacity assessment by a doctor. It's often easy and obvious when a person does have capacity or doesn't. It's those ones in the middle that can be quite thorny, and that's a whole different topic of conversation, which we don't really have time to go through today. But assuming a person doesn't have capacity, then it's also important to remember, at least medical legally in New Zealand, the framework is hierarchical in nature. So I think at the top of the hierarchy is a patient's advance directive in terms of their wishes and preferences. And then the next step down is the activated EPOA, as you say, Laura. Interestingly, if there is no activated EPOA, then the decision falls to the attending physician, and at least legally, family have no actual authority in terms of making decision. That lies with the physician. But I think, the safeguard with that is that with the authority that the physician holds comes the responsibility of consulting and collaborating with all interested parties, with the GP, with the other specialists, with family, and coming to the best decision, hopefully with consensus. So, yeah, it is a difficult area of practice, and you really want to try and bring everyone on board when a person doesn't have capacity. All right. I think I don't see any more questions.
No.
Yeah.
Thank you.
Fantastic.
I think David's just going to share a screen now that I was just going to briefly talk about at the end of the webinar, if that's okay. Yeah, so we just wanted to flag really after that conversation that there is support available from the hospice. So this is the doctor direct advice line. So the number on the screen is carried by myself, Oleg or Celia, 5 days a week between 8 and 4:30 p.m. So if you're carrying across these challenging scenarios and feel that some support from the specialist palliative care team would be helpful, that's the most direct way to access us. Out of hours, we have a 24-hour 0800 number, which patients and families are given when they first join the hospice. And again, professionals can access that line because out of hours, there's also medical support available 24/7. So really, please, if you've got questions or concerns, please let us know, and we're very happy to help out as much as we possibly can. Thank you.
A huge thank you to you, Laura, for leading that really thoughtful and clear guidance on what really is a challenging area. I was really pleased to see you mention the frozen gin and tonic, which I need to update my ACP, make sure that's in there as my liquid of choice. No, but that was really thoughtful and helpful. Thank you very much. And to you and Oleg for that discussion around our questions, which I found really useful as well.
Thank you.
Just to remind you guys that we have our next webinar in September. I think it's the 29th of September, and we will be letting you know what topic area that is. You will get some questions about some feedback for us and what topics you might be interested in the future. I've just heard Oleg talk about capacity and thought that might be a really interesting one for us to address at some stage. So thank you again for joining us this morning, and hope you enjoyed our webinar today.
Thank
All
you
of the
very
best.
much. Bye-bye.
Bye.